Good afternoon, everyone. Welcome. On behalf of the National HIV Story Trust, I welcome you all to this introduction to the forgotten history of the AIDS pandemic, a journey from the earliest years to the opening of the first specialist hospital ward, from the advent of effective medication to what it is like to live with HIV today. We hope this webinar will go some way to explain why there is so much ignorance, stigma, and discrimination around HIV, even today when we have effective medication. You can't understand the present without understanding the past. Our guests today include Winne Sseruma, an international development consultant, Garry Brough, who's worked for the NHS and HIV charities, Dr. Jason Jones, doctor and professional mixologist, Mammadova, a mother of 3 children, Bruno de Jong, a gay father of twin daughters, and Professor Jane Anderson, who's been an HIV consultant since 1984. If you want to ask a question, please use the chat button, and you will find all our details about Twitter and Facebook on your chat function. I'm your guide on this journey. My name is Chris Sandford, and I have been living with HIV for over 40 years. I'm going to start by busting a few myths. 7 basic facts. HIV has been around a long time, at least 100 years. It came from monkeys, just as swine flu came from pigs, bird flu from chickens, and COVID from bats. But it was only identified in 1981. Number 2, HIV is not a gay disease. Anyone can get it. In fact, only 7% of the 40 million people living with HIV in the world today are gay or bisexual. Number 3, in the UK, there are 105,000 people living with HIV out of a population of 68 million. The UK has one of the lowest number of cases in the world. Number 4, HIV is not history. Nearly 1 million people die every year from HIV. Number 5, you can't get HIV from touching, kissing, from cups, from clothing or food. It's actually a very difficult virus to catch. The main ways are through sex, injecting drugs, and mother-to-child transmission. Number 6, for the first 15 years of the pandemic, there was no medication, no vaccines, and 98% of people who caught the virus died. In the UK, 20,000 people have died. Globally, over 40 million. Number 7, nowadays, 40 years after it was first identified, HIV is considered a chronic manageable condition, if you have access to medication. But more about that later. I volunteer for the National HIV Story Trust, an amazing charity that is preserving the history of the AIDS pandemic, remembering the stories of tragedy, but also those of love, compassion, and humanity. We have now filmed over 100 interviews with survivors from the 80s and 90s, their doctors, nurses, and the politicians who, finally, after years of inaction, took the pandemic seriously. We owe this generation a huge debt, and we wouldn't be where we are today without them. Let's take a look at some clips from the interviews we've done so far.
Robbie died on New Year's Eve, so the end of 86, 87. He just escaped having to be buried in concrete. People had to be buried in concrete. I wasn't allowed to view the body.
4 of my lovers died all in the late 80s, early 90s.
We were just at that point, if you like, of feeling hopeful about us. And he'd gone to his hospital and he didn't see his own consultant at that time. But he was told, basically, and it was a word which I don't hear anymore, thankfully, but he was told he was a treatment failure.
By the time Robert came out of hospital, he was 4.5 stone. I could carry him up 4 flights of stairs to his bathroom because he wanted a bath in his bath. You know what I mean? We forget this completely devastating impact.
We were supposed to meet on the Monday, and unfortunately I kept phoning, couldn't get hold of him, and by the Tuesday, when I was phoning, the police answered the phone, and he'd hung himself.
The early 80s and the mid-80s and the early 90s was typified, for me, by burying people. Of just knowing all those people who you knew around on the scene were dying.
Everybody can get over a broken heart, or maybe 2 in their life, right? 30 of them? 40? So when you're wanting to reconnect with somebody, how do you do that? When you know that your guts are going to be pulled out, that you are going to become so incredibly raw again.
I wasn't going to tell my friends because I would sit in conversations and people would say, if anybody with HIV was part of a group I was sitting in, I would just leave, you know. And I was sitting right in the middle of these conversations. And I thought, there's no way I was going to disclose my status.
You know, we were all double gloved and double gowned, and he was kept in an isolation room. All of his cutlery was plastic, paper plates. Even his notes had infectious written on them. We didn't touch them without gloves on. You know, his bedding was burnt. I mean, it was just horrendous.
Nobody thought to test me because I was, you know, straight white woman. I hope it will be different nowadays. I'm pretty sure it will be, but back in those days, you know, I didn't really know any women who were positive.
And I remember one of my colleagues actually years later got diagnosed with HIV. And I was really taken aback because I'd worked with him for years. And at a Christmas do a couple of years later, we were all sitting around. It was a work Christmas do. And he was sitting over there. And he said to no one in particular, he said, "I'm so glad to be alive." And it still chokes me to think of that because I felt the same. It was really emotional, that moment. It still is.
His junior doctor said, does Robbie, you know, I'd like to give him diamorphine, which is a polite way of saying, you know. And I'm going, yeah, fine. He said, does Robbie know he's dying? And I said, yes. And the doctor burst into tears. Doctors and nurses used to go to people's funerals, you know, kind of, because in a strange kind of way, we were all in this together. And I think HIV care, in a way, became the model, you know, the gold standard of care in the UK for the NHS.
And also considering the pain and tears of people from the 80s and the 90s who lived through the nightmares of the epidemic, who've been tested on to get this medication into my hands today. I suddenly felt this responsibility that I somehow need to cherish the lives that were sacrificed.
It seems to me that the history of HIV/AIDS must teach us the value of compassion, must teach us the value of hope, because what seemed utterly dark and pointless and cruel has been treated and has been turned into something of hope. And especially in these days when things are strange and turning, you want to hold up this beacon of togetherness and solidarity and unity.
Thank you, Emma Louise, for your comments about that. Yes, it was very emotive. And As you saw in the video, it was a terrible time, a time of fear, ignorance, stigma, and discrimination. People were afraid to talk about it. People were afraid to tell their friends and family. They feared rejection. They feared dying alone. You heard me talking about my partner. He started becoming ill in 1980 and was diagnosed in 1982. One of the first people to be diagnosed in the UK. He was given 2 months to live. In fact, he struggled on until 1987, during which time he was in and out of hospital for weeks, for months, in isolation. He developed cancers over his body, suffered from pneumonia. Junior doctors refused to enter his room. Cleaners wouldn't clean. Nurses, as you heard, were double gloved. Visitors were restricted. And one day I arrived to find someone pushing a tray of food into the room with a broom handle. HIV was first identified in the United States in 1981 among a group of wealthy, white, gay men, and this is why it was first called Gay-Related Immune Deficiency, GRID, which completely ignored the fact that non-gay people were dying all over the United States and all over the world. HIV was quickly labeled a gay plague. There was an outpouring of homophobia. There was abuse and violence directed against the gay community. People were attacked in the street. They were sacked from their jobs. Their homes were destroyed. One boy I knew had his home set on fire by his neighbors. The council moved him into a flat with a small garden for his cat. One day, he came home and his cat had been hanged. The media fans the flames of this homophobia, incited fear, violence, abuse, and made gay men into scapegoats. Just take a look at these headlines. Gays in fear. They dread revenge. Wife murders hubby with AIDS cocktail. Gays bashed over AIDS. The killer plague. AIDS kills Freddie's 2 lovers. Britain threatened by gay virus plague. The man who gave us AIDS, that's a reference to patient 0. AIDS, the wrath of God, says Vicar. Millions may die of AIDS. AIDS virus kills man in Britain. Blood from gay donor puts 41 at AIDS risk. A pneumonia that strikes gay males. I'd shoot my son if he had AIDS, says Vicar. Quarantine plan for AIDS. AIDS sweeps the nation. Appalling headlines, appalling behavior, and this in a civilized country. Looking back now, I wonder how we coped with this onslaught. And there was worse. One day I saw a car sticker which read, "Stamp out AIDS, kill a queer." As I've said previously, HIV is not a gay disease, and I'm now joined by our first speaker, Winne Sseruma, who was also diagnosed in the 80s like me. Hello, Winne.
Hello, Chris.
Right, okay. Thank you for joining us. In the video, you talked about having to hide your diagnosis from others. How did you deal with that? How did you overcome that fear?
Well, it was really difficult when I was diagnosed with HIV 33 years ago now. I was in my late 20s, thinking, you know, I had my life ahead of me. It was really difficult. As a Black woman, I'd never seen another woman with HIV. I'd never, you know, heard of another person like me living with it. But I'd heard a lot of talk within, you know, the Black communities and specifically in African communities
around HIV, and the stigma was unbelievable. As I said in that film, I would sit in the middle of conversations with acquaintances, with friends, and they would come up with the most ghastly things, you know. They would not sit in a same house with a person living with HIV. They wouldn't let them use the toilets. And so for me, sitting in the middle of those conversations, there was no way I was going to disclose my status. And so not being able to talk to anyone, especially friends or acquaintances, it was very, very stressful. It was very difficult. It was incredibly lonely. Also, my whole family, were in Uganda, and I was by myself. All my siblings were in Uganda, and I couldn't reach out to talk to them, to tell them that I was, I had HIV. So it was very, very, very lonely. And it took me a long time to be able to disclose my status. I think it was through accessing some support through a support group that I was able to be able to disclose my status. But the thing is that being a woman, I wasn't only dealing with, HIV as a woman. It was also about being what people thought was a migrant. And then also the sexism, there's the racism. You showed in those clips, Chris, that, the media were talking about the gay disease and, the gay plague. And as people continued to understand that it wasn't just about gay people and it affected other communities. And the second most affected communities were Africans. Then the media jumped onto the anti-migrant sort of bandwagon. HIV migrants, let's get them all back to where they came from. It was absolutely terrifying. It was nasty. It was painful. It was unkind. But I think what was most difficult was that the places where we thought we could get support or solace from, those places were also spewing all sorts of, stigmatizing messages. There were churches, church pastors, talking about all sorts of things, like, if you have HIV, you've been bad, you can't come to church. There were all those things. Then, it wasn't just even the churches. If people had jobs, there were organizations and institutions putting policies in place that, that deterred people living with HIV from getting jobs. They were putting travel bans on people living with HIV. You couldn't travel because you had HIV. So there was a lot going on, and all that stuff added up, and it was really stressful. By the time I started to speak up in the mid-90s, here in the UK, a lot of African people were dying. And the NHS really was not didn't have systems in place dealing with whole families, like a mother, a father, and children living with HIV. Yes, they were able to actually, deal with gay men, and they were the most affected at that time. But there were no social systems in place to support, African families living with HIV. So as I started to understand what was going on with me, and I started to learn a lot more about HIV and survived long enough to be able to access treatment in the mid-90s, I started speaking up. I started to join other Africans here in the UK who were working to help support people in the communities, in the homes, everywhere. But I can't explain how bad it was at that time. And it was layered. There were so many different intersectionalities. And as you said, Chris, I really, even now, as I speak, I don't know how we survived. But to quote, a few people, we're resilient. We're empowered. We empowered ourselves with knowledge. And in the words of Elton John, we are still standing after all this time.
Great, Winnie. Thank you very much. We have a few questions which have come in. So I was horrified. This is from Jolene. Yes. While I was horrified, I was born in the 80s. So whilst I remember the scary advert and the horrible headlines about Freddie and Kenny, I was ignorant about how bad it was. Were you aware of that most people were ignorant of what was happening at the time?
Well, there was a lot of denial within the communities. So people didn't talk. Even people who had people living with HIV within families did not talk about this because of the shame. In the churches, they didn't talk about it at all unless they were demonizing people, the bad people who got HIV. So there were a lot of people who didn't go to test, and we know now that testing early is key. There are a lot of people who died from all sorts of HIV-related impacts. But even then, even in death, some people living with HIV and their families used to say, please don't say they died from HIV.
Yes, I remember that too. They used to put different things on death certificates. One last question is, do you think ethnic minorities are actually represented in contemporary HIV discourses? This comes from Fernando.
There is representation, but it's not enough.
Right, okay.
You could do better.
Fernando, I hope you're happy with that. That's a really good thing. Winnie, thank you so much for joining us. That's really nice of you to join us, and see you soon.
Thank you for having me.
In 1987, things started to change. There was a glimmer of hope. In April of 1987, Princess Diana opened the first ward dedicated to HIV care. She shook hands with staff and patients without gloves, including a young man who was very ill with HIV. This action started to change people's attitudes. Unfortunately, he died a few weeks later. Let's take a look at the news coverage.
The Princess of Wales felt not the slightest apprehension about her visit to the Middlesex Hospital and its AIDS ward, according to press reports. All speculation had centred on whether she would wear gloves when shaking hands with the staff and patients on the new ward. But as she entered, to the delight of the staff, she clearly wasn't wearing gloves. And she shook hands with all the nurses, doctors, and all 10 patients on the ward. She stayed more than an hour, but was not filmed with any of the patients. They were worried about public exposure. Only one agreed to be photographed.
Ward visit was private. That's what the patients wanted, that it was purely private. She met 10 patients. She shook hands with all of them. When appropriate, when they were in bed, she sat on their bed next to them and was very natural indeed. To see a person in public life coming to a ward, sitting on patients' beds, touching patients, shaking hands with them, exchanging words with them, of course, that does help tremendously to dispel any remaining sort of myths and anxieties. Of course, it's a very useful visit in that sense.
Thank you, Kevin, for your comments about that. Kev, I'm now joined by our next speaker, Garry Brough, a great mentor and friend who was a patient on that ward. Hello, Garry. Hi, welcome. Thanks for joining us.
Yeah, you're welcome. Thank you.
You must have been very ill to be admitted onto that ward. What was it like? What was the atmosphere like on the ward?
It was a little different by this time, as it was the kind of the early to mid 90s. And so I've been living with HIV for about 31 years. And I had several years of good health before getting ill. But when I did fall ill, it was the Middlesex was my hospital, and so that was the ward that I was admitted to. It was a very strange experience because by that point it wasn't like hospital. They had done everything that they could to have changed the approach to patient care by then. So that very old school, almost carry on representation of what a doctor, a matron, the sister, what they all looked like in uniforms had changed completely. The Brodrick ward had very quickly cottoned on to the fact that if people were going to be admitted into that ward, first, there was a very good chance that they weren't going to leave the ward. But more than that is that while they were there, they needed to be careful. They needed to be cared for as people, as human beings, and not as just another patient. And so by the time I was there were no uniforms for the nurses. There were no visiting hours. So if somebody wanted to come and visit you, they could come and visit you. And there were endless stories of people coming in and somebody feeling good enough to just pop out, and so they'd pop out and go to a club for a couple of hours and dance, and then come back in and collapse into their bed. I never did that myself, I must admit, because when I was admitted, it was with lung problems due to Kaposi's sarcoma, first on my skin and then in my lungs, and so I couldn't breathe, and so there was no chance that I was going to go dancing. But the care from the staff on that team was phenomenal, was personalized. You already mentioned the fact that healthcare professionals attended funerals. I felt like I was being cared for by people who genuinely cared for me, not because they were nurses, but because they were there to provide that support. And here are some of the images that were photographed over the early 90s in that ward. And they show, people like myself, their friends, family who were in visiting, in both the comfort and the pain of that situation. It was an incredibly challenging place in the one respect. the beds in the early 90s when I was there were always full. By that point, there was not just Broderick, but Charles Bell across the way as well. So we had 2 wards. They were invariably full. And if there was a bed empty, it was because somebody had just died. And that was the fact of it being in there. But the ability to go and have some space, to have a chat, to have friends and family visit. You can see there you are, the people in their jumpers by that point. Ade was my doctor when I was on the ward. I recognized a lot of the people in these photographs, particularly the staff members, and an occasional white coat that you see there. But it was meant to be a home from home. It was meant to be a place where you could go and be comfortable and be taken care of by professionals, but in a way that didn't feel too clinically focused. I remember being awake one night late and a nurse coming around, and they would just come around just to check whether people were asleep, and then just sit and chat, hold your hand, and ask what was going on, how you're feeling. And so it was a great reassurance to be there, having been admitted to other hospitals where I lived locally rather than that one. I checked with my doctor afterwards, and they said, no, you can ring us rather than ring an ambulance, and we will pick you up if you need to be hospitalized. Because the quality of care and the personalization of that care there was exceptional. And I was hospitalized various times with Kaposi sarcoma, with pneumonia, with meningitis, with septicemia. And so it was really only with the advent of effective medication that all of that changed, and that I had a second chance. I was lucky enough to have survived long enough that when medication became available, I was literally pulled back from the brink with a CD4 count of 10. It was my immune system was decimated, but I was nursed so professionally through that, and with such love that I'm still in touch with some of the people that cared for me on that ward. Some of whom I see in the clinic still, some of whom I play Scrabble with through apps. But it was an amazing place.
I think I was on Charles Bell, you were on Broderick, and I can always remember that awful moment. In the worst moment of the night, you listened for people's breathing and dreaded if it stopped. And Garry, that was very, very moving. Thank you very much. We've got lots of questions, particularly about stigma and things like that. But I think I'll take Zoe's question. How well did Itza Sin portray the HIV crisis?
For me, it was like some kind of acid flashback, to be honest. It felt exactly like it did at the time. I came to London in 1985, where, and so that era was so well represented. The scenes of clubs, the scenes of hospitals, thankfully, were better by the time I was hospitalized. And so it was those later years, but really the experience, the confusion, the doubt, the denial were all so eloquently put. My only regret with the show is that there wasn't the space for those extra episodes that would have taken us to where we are today, which is such a different story. And that's, but I adored Itza Sin. It made me laugh, cry, angry, all of the things that I experienced at the time. It just reconnected me with a period that was, that feels now like a different life, actually, and another lifetime ago. It was a great thing to be reminded of and to be brought back to.
Great, thank you very much, Garry. And one last comment from Morris. You're looking great.
Thank you.
Okay, thanks very much, Garry.
Thank you.
In 1996, a miracle happened. 15 years after HIV was first identified and after millions of people had already died, that year saw the introduction of effective medication. Our next guest is Professor Jane Anderson, who has worked in HIV since 1984. Hello, Jane.
Hello, Chris. Hello, Chris. Well, thank you so much for the invitation to be part of this webinar today. I'm a doctor. I work at the Homerton Hospital and at Barts Health now. And you've asked me to think a bit about what it was like then and what it's like now we've got better treatment. So I first heard about AIDS 40 years ago in 1981. I was a medical student then at St Mary's Hospital in Paddington, and that was one of the first hospitals to care for people with AIDS. And it's important, I think, I want to just make sure that people understand that AIDS stands for Acquired Immune Deficiency Syndrome. It's a syndrome, a collection of illnesses that happen when the body's immune system has been so damaged by human immunodeficiency virus, HIV, that serious infections and cancers can't be resisted anymore. And so what I want to just reflect on is that AIDS and HIV are not the same thing. HIV is the cause and AIDS is the effect. And so today in the UK, most people living with HIV do not develop AIDS because they can take effective medication, antiretroviral therapy, or what's shortened to ART. And that treats the HIV infection well before the immune system is so badly damaged. And sometimes when you're reading, you see HIV/AIDS, and it's important to actually, I think, keep that distinction. But more about treatment later. You're quite right. I qualified as a doctor from St Mary's in 1984, and my very first job as a newly qualified junior doctor was with the immunology team at St Mary's, who had responsibility for all the patients with AIDS who were ill enough to be in hospital. And most were young men. Most were very sick with unusual and complicated infections and cancers. And I think you've heard from other speakers, very many of them died. And as a young doctor, it was a huge learning experience. Every part of the body could be affected. There were lung infections, so people found it very hard to breathe. Problems affecting the mouth and the gut made eating painful, caused terrible diarrhea, and many people lost a lot of weight. Infections in the back of the eye meant people lost sight, went blind. There were brain infections causing problems with the nervous system. And as Gary's alluded to, a cancer called Kaposi's sarcoma added purple patches on the skin. And both Winnie's referred to this as well. There were not very many women at that time, but it was important to remember that there was the ability of the virus, HIV, to pass from mother to baby during childbirth. And that meant that pregnancy, having a family, was incredibly difficult. And there were some very small numbers at the time of babies who were acquiring HIV through birth. So as doctors, which is what you asked me to reflect on, a really big part of our job was to work out the particular infection that was causing the problem and the symptoms in order to try and get that infection under control. So we couldn't control the HIV, so we had to try and control all the other things that were going on. And often there'd be more than one infection or problem at a time. And again, Gary's alluded to this, because the immune system was so damaged and there was no treatment for HIV itself, no sooner was one problem treated or dealt with, then another one would come along. So people would go home, they'd come back, and a lot of time would be spent in and out of hospital. And some of these conditions were very rare and required all sorts of investigations to find out what was going on. And simple conditions often turned up in really unexpected ways, and the whole thing was a really very complicated medical risk. And you've heard a little bit from other speakers about stigma and fear, and it was quite the case that it was not uncommon that concerns about infection risks meant that laboratory tests, biopsies, surgical procedures weren't always easy to get done. And I think we learned very quickly that we had to advocate, we had to negotiate, and we had to get the right things done right. It was nice to hear Garry say that it felt like a safe environment, because I think there was a lot of work that went in to try and make sure that was the case. And of course, when a diagnosis was made, the treatments for those complications were often unpleasant, they were prolonged, they themselves had side effects. And so there was a combination of recurring bouts of severe ill health, complex, difficult treatments, and they all had a really big impact on the day-to-day life of patients and their partners and their families. And I think you saw some of that in those photographs. And you've heard it from other speakers, but there was a lot of fear, a lot of stigma. People didn't want others to know about their diagnosis, and that led to often even greater isolation. And there were times, even after calling on the expertise of many different specialists and some of the most senior doctors in the hospital, we didn't have answers. Yet I want to just go back, because in that period we learned so much. We learned from other clinicians in other hospitals. We learned from people in other cities, in other countries. And many of those who taught us saw that things had to be done differently, taught us how to say, I don't know, showed us how to ask for help. And many of them demonstrated real bravery in trying out new solutions in the face of very difficult problems. But I think in particular, as a younger doctor, we learned from the people who were sick and the people who were dying. We learned from their friends, we learned from their communities, and we learned from community activists who were often in touch with other community activists in other countries. And we learned at that point that health is political. We learned about love, we learned about loss, and we learned about the difference between treatment and care. We learned to look out for and look after one another. And I think we learned ways of practicing both the art and the science of medicine that has influenced the generation of us all. And of course, during all that time, there was really intense interest in finding effective treatments for HIV, but it was slow in coming. The first drugs in 1987 was one called AZT, and many of those early medicines, taken one by one, they weren't very effective. They were difficult and they had unpleasant side effects. They didn't work terribly well. But as you said, Chris, it was in 1996 things changed. Not only were new types of drugs being developed, but we realized that using them together in combination was the key to success. The ability of ART to stop the replication of HIV, which is called the viral load in the bloodstream, is a measure of the drug's efficacy. And the holy grail for all of us with these medicines is to get the HIV replication to such a low level that it can't be detected by laboratory tests. It doesn't mean it's gone, but we can't detect activity. And that is known as having an undetectable viral load. And often today, people refer to being undetectable. People refer to themselves as being undetectable, which means the drugs are working and the virus is not dividing. So we entered a new era where effective treatment really was becoming a reality. People stopped dying. By that time, I was a consultant at St. Bartholomew's Hospital, and the ward there, which was always full, we actually managed to close some beds, and we turned one half of the ward into a day unit because we didn't need as many inpatient beds. And of course, once it was clear that treatment was effective and available, then testing for HIV became absolutely imperative to make sure that people could actually receive treatment and stay alive at that point. And of course, once testing became more regular, the numbers of people with AIDS began to fall, and overall people's health began to get better. And we began to have conversations about stopping smoking and having a better diet and taking more exercise, because you know what? You might be alive to live well and to enjoy good health, which were conversations we would not have had in earlier times. And we began to see, too, the research showed us that people who started treatment as soon as possible after infection did far better than people who started treatment later. I'm not going to say treatment was always easy in those early days, but over the years, many new drugs have been developed, and they're becoming ever more effective, safe, and free of side effects. And today, most people with HIV can expect to take 1 or 2 pills a day and remain undetectable. And just over the horizon are longer-acting medications that will reduce the number and the frequency of tablets, and we are beginning to look at drugs that can be given by injections every few weeks or months, which is going to change the landscape even further. But what about prevention? Well, by 1999, all pregnant women in the UK were offered HIV screening as part of routine antenatal care. And if they were positive, they were offered treatment. And the numbers of babies born with HIV in this country fell dramatically, and women living with HIV lived better. It's become increasingly clear that people taking effective treatment are no longer infectious to their sexual partners, highlighting the importance of treatment as a way of preventing infection. And this, it's been alluded to in the chat, but if you have an undetectable viral load, it is you can't pass the virus on. So undetectable equals untransmissible, which in today's parlance is shortened to U equals U. And for people who are HIV negative, taking antiretroviral medication before having sex prevents them acquiring HIV. And this is known as pre-exposure prophylaxis, or PrEP. And I've got to say, it's been a struggle, but in the last year, the UK government has agreed to fund PrEP for everyone who could benefit from it, which is amazing. So what an extraordinary transformation. Even just in the course of my own professional career, from a time when everybody with HIV could expect at some point to be very sick and eventually to die of AIDS. People with HIV now who are diagnosed in time with access to today's medicines can expect the same life expectancy as the general population. They're not infectious to sexual partners, and they can expect to have a family without fear of passing HIV infection to children, and they can expect to become grandparents. And people who are HIV negative are able to access effective prevention methods to stay that way. But as you've heard, the fear and the stigma associated with HIV have been so much harder to shift, and they still stand in the way of progress. And I'm so pleased that this webinar is happening today, because education is absolutely critical. This initiative is so important. We need to get the word out for people to understand that people really know how HIV has changed and how important it is to get tested and to find out whether you're positive or negative. The gateway to this is testing. If the test is positive, there are effective treatments, and if it's negative, there are plenty of ways of making sure it stays that way. So to finish, I'd just like to say, while we remember the many, many whose lives have been lost or damaged along the way, and acknowledging everything they have taught us and all that we have learnt, HIV must no longer be allowed to stand in the way of a long life well lived. Thank you.
Thank you so much, Jane. That's wonderful. And thank you for explaining what U equals U actually means. We have lots of questions here. And also a lovely comment from Maureen. We celebrate all our living legends. We salute you guys, which I thought was really nice for all of us. There are a couple of questions. Max and Morris have asked the same things, really. What lessons could be learned from the HIV pandemic for making sense of the current crisis?
No, I think that's a really important question. And just hearing about the fear, the stigma, the sense that things happen to other people, that things happen in other countries, they don't happen here. They're all parallels. We heard that at the beginning of the HIV epidemic. Oh, it doesn't happen to me. It doesn't happen in our country. I think things, the parallels between wearing masks and using condoms, both to protect yourself and to protect other people. Of course, we don't yet have an HIV vaccine, and we do for COVID, but actually remembering, and I think Gary's points here, that people are people, whatever is happening to them, and caring for people is absolutely central to this, and addressing the fear and the stigma that goes with infections that kill people.
And a lovely question from a comment really from Esme. I'm 17, and before It's a Sin came out, I had no idea about the severity of this. How do you think is the best way forward with my generation?
Yeah, no, I think that's a really important point. My experience of learning about things in HIV is people learn most from their peers. And so actually it's how I would turn to you and say, how do 17-year-olds find out about things? Should we be using social media more? Should we be making sure that the HIV history story, how do we communicate with you? And actually, I'd like to have a 17-year-old as a consultant on that question, because you will know answers that I won't have even thought about.
Esme, keep in touch with us via the website. Jane, thank you so much. Thank you very much. And thank you for explaining exactly what undetectable means, U equals U, and the fact that HIV is now considered a chronic manageable condition. Thank you very much indeed.
Thank you for having me.
Well, everybody, my last guests are three people who are all living with HIV, were diagnosed in the last few years, and who will share what it's like to live with HIV today. If you'd like to switch on your microphones and cameras, that would be wonderful. Jason, hi. Lovely to see you. Is Amanda there?
I'm here.
Amanda, hello. Bruno, are you there?
Hello. Hello. I'm here.
Hello. Oh, yes, there you are. Fantastic. Thank you very much. Hi, guys. Thanks for joining us. And particularly thanks to Jason for joining us from his hospital. He's the one in the mask. Okay. Amanda, I'm going to start with you. Okay. The first question is, this comes from Abby. Do your children and partner have HIV?
No, they don't. So I was diagnosed in 2010, not really knowing much about HIV. I was born in the 80s, but really didn't know much about it. So kind of assumed when I was diagnosed that I wouldn't be able to have any children, no one would ever love me, I'm never going to be able to find a partner, and so on and so on. But yeah, since 2010, I've made 2 more babies, and yeah, my partner and my children don't have it. Because I'm undetectable, I'm on medication, and I was on medication through my pregnancy. So yeah, it's not passed on.
Fantastic. And when did you tell your husband?
So it's a bit of a weird story with us, because we met whilst we were both working in Turkey, and he couldn't speak my language and I couldn't speak any of his. So it did make communication really, really difficult to start with. So I came back from Turkey thinking it was just a holiday romance. Then I was going through the Territorial Army recruits phase, and I wanted to go full time. So I went for a routine health check, eyes, teeth, sexual health, everything. And the news came back that I was HIV positive, and I didn't really know what that meant. I just thought, I'm going to die. So I had to phone Ali by Skype, and I tried to explain to him and put it in the chat, and he didn't understand it in English, of course, because he didn't really speak English at that time. So I translated it through Google Translate into Russian, which he kind of got, and then I translated it into Turkish, and by that point I think he'd got the idea as to what I was trying to say, and assumed that if I have it then he must have it. And it was very much a case of, well, how do we deal with this? What do we do? Which was completely not what I expected, because I was due to fly out to see him 5 days later. And it was a choice of, I either tell him here while I'm safe in my own country and kill the relationship, or I fly over to Azerbaijan, tell him to his face and kill the relationship. There was never any thought that we could move on from this and everything would be okay. So told him, and he was absolutely fine about it. So went over to Azerbaijan in February, and yeah, just had a bit of time there, and Ali proposed. So I agreed, and in his very broken English, proposed to me. And then I came back in the September 2010, and we got married.
Thank you so much. Okay, Bruno, for you, yes. You have twin daughters who are 10 months old now. As a gay man, did you encounter any problems with becoming a dad?
Yeah, I guess in a way we did. We went to the fertility. I remember going to the fertility show in Olympia. That was probably 2016, and we were talking to several surrogacy agencies there. And there was this one agency from America, I think they were from Boston or something. And once we told them we were HIV positive, I remember the lady turning to us and saying, "Oh no, we won't be able to work with you." And my husband was crying and everything. And in the UK as well, if you are in a gay relationship, you can't, and you're HIV positive, you can't do surrogacy through the clinics here. They won't work with you. It's something with the law. And because that's seen as sperm donation if you're not in a straight relationship. That's seen as a sperm donation. So we couldn't. UK was not an option for us. So we ended up going to Canada, which was very welcoming, very open about the whole thing. As soon as you said about the HIV, to the one of the biggest clinics they have in Toronto, they were like, "Yeah, we have loads of clients with HIV, not a problem." And so a few, we had to do our research. So there's still a lot to change, I think, in the world with regards to that.
But your daughters don't have HIV, do they?
Oh no, not at all. No. Yeah.
Thank you, Jason. A question for you. Thanks for joining us. Not many people know that you can do any job if you're living with HIV. You were diagnosed when you were a medical student. How did you deal with your diagnosis? And that's a question from Sam, by the way.
Well, I mean, even when I was diagnosed, I think at the time, just before I was diagnosed, there were only 3 jobs that you couldn't do at the time. And then when I was diagnosed, my immediate concern was initially about my career. I thought that it was going to completely ruin my chances of not necessarily being a doctor, but certainly limiting my options. And actually the advice that I was given at the time from some very well-meaning healthcare professionals was that it could well do. But don't worry, there are still plenty of options available. And I actually went home with leaflets that they gave me and found out that only the year before had the rules changed about being a doctor. And now, so long as I take my medication and I remain undetectable, I can do whatever I want. It just so happens that I hate surgery anyway. So it's never really been an issue, but it was just the immediate relief, I think, from my major concern being my career. Everything else paled by comparison. Dealing with it as a medical student was much easier, I think, because I had the educational background to already know that it was no longer a death sentence, to already know that it would never affect me in the ways that it used to affect so many people. And I was very privileged in that regard, in that it did not really upset me all that much, or anywhere near as it should have. Certainly not as much as I thought it did. And it wasn't until I first turned up to my very first session at a newly diagnosed course being run by our friend Chris here, that I realized around the room just how many sad stories there still are about being diagnosed, and just how terribly people take it. And it's all down to education. These people still hadn't been taught how things had changed. These people still hadn't been taught about medication changing the face of HIV and changing it from a death sentence into a livable condition. And it was only at that point that I realized just how lucky I had been in that position. And I hope through educational programs like this, anybody else that gets diagnosed, and fingers crossed it will be fewer and fewer people every year, that they can be diagnosed with sort of just a breath, that it's something that you just have now, but don't worry, it's not going to change your life in any way.
Right, thank you very much, Jason. Yeah, that's absolutely brilliant. Thanks for answering that. A comment from Deborah. Amanda, your daughter is beautiful. But back to Amanda. Kesh asks, which is worse, having HIV or people's ignorance?
People's ignorance every time. HIV, I'm quite lucky that it doesn't really make much of an impact on my life. I take one tablet a day, and that's it. That's really as dramatic as it gets. Apart from I go to the clinic every 6 months to have my bloods checked. So the HIV itself doesn't really cause me any problems at all. The same as any other illness or anything. If I have a migraine, I take medication for that. So it's for me, it's on par with that. But people's ignorance, wow.
Jason and Bruno, do you agree with Amanda?
Absolutely, yes.
Yes, absolutely.
All right, I'm glad you agree. Right, okay, Bruno, this is one for you. It's from Poppy. Did you find it difficult to have relationships after your diagnosis?
It's a funny question. I did have, say, a couple of people that I was going to go out with, that I said, "Oh, I'm HIV positive," and then there was sort of silence, and that was that. But funny enough, 2 months after I was diagnosed, I met my husband. So, and that was absolutely fine. I told him quite quickly. So he was very warm, informed about the whole thing. So yeah, it's a funny question because I didn't have many relationships after I got diagnosed. I just got married. So yeah.
And anyway, if somebody turns you down, do you want them in your life? I think that's
exactly
the thing that we have to consider. And the final question is from Kevin, and it's for Jason. Do you think undetectable means untransmissible is understood by the general population?
Well, forget about the general population. I know several doctors that don't understand it. I also know that there are many people in the HIV community that don't really understand it, let alone the ignorance amongst communities affected more predominantly by HIV than other communities and the stigma that still surrounds it. It's never been within the realm of possibility, I think, in a lot of people's minds that this would be a piece of information that would exist. But U equals U does not mean that you have a low chance of catching it from someone. It does not mean that you have a negligible chance of catching it. It doesn't mean a few cases now and again slip through the net. It means no cases at all. That as long as a person is undetectable, they will not transmit HIV. And, working in the medical field where we're coming into contact with bodily fluids all the time, and when I would sometimes get handovers from people where they'd ask me to go pop a cannula into someone or something like that, and it would immediately be followed by a swift comment of, "Oh, by the way, they've got HIV, so make sure you wear gloves." And most of these people were healthy individuals who were in hospitals for different reasons, who were on medications. And I mean, you should be wearing gloves for anyone you put a cannula in.
I think there's a comment coming from Simon, who's a doctor as well, who says that he has to spend a lot of time educating his colleagues. So I think yes, I think there's a lot of education to do, and that includes, I think, healthcare staff as well. Thank you all so much, Amanda, Bruno, and Jason. Thanks very, very much for joining us, and that's absolutely wonderful. And thank you very, very much for joining us. See you all soon.
Pleasure.
Thanks for having
me. Time has caught up with us, I'm afraid, and I know many questions have not been answered. However, I hope that you have a greater understanding of the forgotten and hidden history of HIV and how it still impacts on the lives of people living with HIV today. We now have the opportunity of stopping new infections of HIV in the UK, but we have to see this as a global challenge. Millions of people do not have access to medications yet, and no country can be safe until all countries are safe. Now, thank you so much for your questions. You can, if you've got burning questions to ask, I think, please get in touch with us via the website. It will come up at the end. And in the meantime, I would love you to fill out our questionnaire, which you will find in your chat function. That would really help us, and it will help help us develop future programs for schools, colleges, and other organizations. Thank you all so much for attending this National HIV Story Trust webinar. All 300 of you from around the UK, Spain, the US, and Australia, where it's now 3 o'clock in the morning, apparently. So thank you to all our speakers and our technical team led by Vanessa. And if you have any burning questions, as I said, please get in touch via our website, and please, please, please fill out the survey. Thank you all once more for joining us, and have a great evening. Thank you.